Hi, everyone, and welcome back to Welln'ish. I'm here again with Liane De Cubellis. She's a pelvic floor physiotherapist, and today we are going to be doing part two, where we'll be discussing everything prenatal, perinatal, and postpartum. So Liane will be explaining to us what the pelvic floor physiotherapist role is in preparing for pregnancy, during pregnancy, and in postpartum. So I'm super excited. Welcome, Liane, or welcome back.
Thank you. Yes, part two. I'm ready.
Yeah.
Let's do this.
And just for those of you who haven't heard part one, we do talk about some fundamentals about intra-abdominal pressure, the link between the core and the pelvic floor muscles. So highly encourage you to read that, as it will very likely be applicable to this episode also.
Absolutely.
Right.
It was a great episode, and I think it could really be relatable for anybody and everybody. This one is a bit more specific to a certain type of population, but the other one is definitely relatable to anybody. Yeah.
Even men.
Yes. Athletes, CrossFitters, we talked about that. Trainers.
we talked a lot about CrossFit.
It was fun.
All right. So how can a pelvic floor physiotherapist play a role during pregnancy?
Sure. So, of course, we treat a number of dysfunctions that they could present with, such as, incontinence or some heaviness in the vagina, prolapse, and any pubic symphysis, or like that general kind of pain that someone would present with, even if they were not pregnant. But I would say a large part in what we do is truly prevention. So, we're talking about prevention of urinary incontinence, so again, leaking, and, prevention of prolapse, which are quite prevalent with women who are pregnant and postpartum. And so I would say the most important thing that I want to get across and what women can sort of expect when they're consulting during their pregnancy is we do a lot of education. So that really looks like having a better understanding of the muscles surrounding that abdominal cavity, that internal unit, how the core sort of lengthens to create room for their baby, but also their pelvic floor, where it is, how to connect and become more mindful of where the muscles lie in the pelvis. For example, how to connect with the muscles. So we do some pelvic floor muscle training, and the goal is to really find out if they're properly contracting and lengthening their pelvic floor muscles, getting that full range of motion, optimizing their strength, endurance, their flexibility, coordination, and so on. So it's not just about the Kegels, but really utilizing their muscles in a variety of different ways. And of course, understanding how to do those pelvic drops, which are really going to be important for pushing. So there is more like of a birth prep section that I like to call it, that we do later throughout their pregnancy, closer into their third trimester, where we sort of shift our intention and we focus more on like their delivery, the ways that they're pushing, which I feel like might answer some questions regarding that later on. But we also would show them, for example, like the perineal massage and things like that to make their muscles like more flexible, and just understanding also how to allow the muscle to relax into some very intense and sensations during like the contractions and the pushing stages. Aside from that, I would say, again, like a bunch of education regarding the hormonal changes, ergonomic positions to be more comfortable when they're sleeping or sitting. I think I said hormonal, yeah, the ligament laxity. What else? And just relieving any like discomfort that they're having related to their pregnancy.
Absolutely. So I was wondering, you talked a lot about breathing, and we mentioned this in part one also, is the dynamic that it has with the core. I was wondering, during pregnancy, is it important to have an internal exam when they're learning how to breathe, whether that be during labor or for pushing? And why is that important?
An internal exam is really valuable for us because it really allows us to get a better understanding of what's happening like inside in the pelvic floor muscles. It's a lot easier to just access and to feel the contractility, but also allows us to feel for compensations. So for example, if someone is clenching their glutes or using their inner thighs, blocking their breath, I could feel that pressure in my finger. When we're teaching the relaxation, and sort of, especially for pregnant women, teaching them how to open their pelvic outlet for pushing, and allowing the baby to enter the birth canal, we could really, use those cues and that like manual feedback, which they appreciate because they could sort of feel the feedback that I'm giving them. That tactile feedback can allow them to feel how to bear down or how to contract like against my finger. But I can also feel the tailbone lengthening away from the pubic bone and the ischial bones like moving away from each other. So we physically feel the perineum lengthening down and out, and if they're doing that properly. There is a way to observe on the outside. So we lift their knees up at 90 degrees and we can visually see if the perineum is descending, but it's just less accurate and there's less ways of being sure if there's any compensation. I will say also, in addition to the first question, what I really find so nice about consulting before is that the women who come and also the therapist have the chance to get a baseline. And so that means that you are getting the opportunity to know what it feels like to contract your muscles with no injury and no trauma, or no, maybe this is like your first pregnancy, it could be your third, regardless of how many you've had. It allows you to compare your before and after. So if you did have a difficult delivery, you could very well say like, oh my gosh, my muscles are completely inhibited. I'm not able to hold it in like I used to, or my endurance is really being affected. Or I can compare and say, oh my gosh, your tone or even like the appearance is not what it used to be. So let's try and work to sort of restore those pelvic floor muscles, whether or not you're symptomatic. So I feel like women really, really appreciate that,
Absolutely.
Yeah.
So in movies, we always see, it's always the same visual that we see in giving birth. It's a woman on her back, bearing down, screaming, red face, barely breathing. So I was wondering, do you see a problem there? And then if you could teach us, I know everything is different between people based on their weaknesses and compensations, is what should a proper push look like? And what do you recommend usually to your clients before they head into the birthing center?
I love this question. All right, where to begin? So we know through studies and research, and I have some to refer if you like after, that the Valsalva, which is blocking your breath, is not the equivalence of bearing down. So for all those who had their nurse be like, you need to block your breath and push, it doesn't mean that because you're doing this, that your perineum is actually bearing down. You're just really increasing that intra-abdominal pressure. And that could look like your eyes, like having some popped vessels and like just really straining and bearing down. So for women who do not access their pelvic floor enough and are not able to really push and bear down from their pelvic floor, they might have to maybe block their breath because that's the only option that they have working for them right now. You know what I mean? But the ideal way to do it is definitely to keep that open glottis and to do more of an open breath pushing. So there's different like ways to sort of have that resistance. There's like these homes and it's like you're blowing out birthday candles, and having that sort of resistance. But it's important to practice doing that while bearing down and opening your pelvic floor. Because as we learned in episode 1, naturally, when you engage your core and exhale, this should cause the muscles to actually contract in your pelvic floor. There's 2 exceptions to blowing out and to bearing down. It's pooping and birthing. Those are the 2 times that you're going to use your breath to exhale and to sort of use that pressure and open the pelvic floor. So we do know that the open glottis pushing is more favorable, but I will say that we do need some more evidence in the literature to really like push it amongst like the doctors and OBGYNs.
I see.
But we definitely keep them more open-minded and mindful of that. We try to anyways,
Okay, that makes sense. Are there certain positions that you suggest to any of your patients in terms during labor or delivery to try or?
Right. Positions are a bit tricky depending on if you have the epidural or not. I will say that the choice is super individual and they're equally good choices, but it does take a certain amount of like research and preparation. And so I always encourage my patients to sort of understand the process and embrace it with, truthfully, I feel like consulting in pelvic health really allows them to connect to their bodies and understand the processes and the changes that are happening and become more intuitive and just know how to work with their bodies instead of working against it. Because as we know, one of the intuitive responses that a human or any animal has to sort of a lot of pain is to clench in anticipation of that pain. So if we're holding in our muscles and we're clenching, like a dog, who's scared, they're going to tuck their tailbone between their legs. And when they're happy, they're going to waddle their tail back, right? We're very much the same. Exactly. So in that moment that we're having this strong uterine contraction, we're going to just want to brace and clench every single muscle in our body. So we have to practice what that means to let go and how to breathe, through the contractions, being more mindful of like what the pelvic floor is doing, how it's responding, and what the core is doing as well. Oh yeah. So going back to your positions, hang on, I got sidetracked. We were talking about the positions giving birth. Okay, so with an epidural, we're limited into 2 positions because we don't have the use of our lower extremity. So that would be like a lithotomy, which is a back position with your feet up in the stirrups, or it could be in a sideline position. I do have to say that we don't have evidence that is strong enough at this point to recommend one birthing position over another. However, I will say that the flexible sacrum position appears to be more helpful. There have been some studies, again, like not grade A level 1, super strong, but there have been some that I've come across that definitely will, for example, say lithotomy led to greater injuries in comparison to like a squat, all fours, or like a sideline position, which, guys, it totally makes sense because if you're on your back, think about the sacrum and the coccyx being immobilized against the bed, and it can't work backwards to open the outlet. So if the outlet can't move back, it's going to have to give elsewhere, which could look like the front, and that can increase trauma, especially for like larger babies or certain considerations. But I will say this is that I find a lot of moms can really bear down and open properly on their back. And then when they go on their side, they're not connecting as well. And this is something that we totally practice is like, I'll ask them if they favor a certain position or if they've thought about it. And if they did, we will practice them together, and it could be a squat. You know what I mean? Okay. I'm going to be having my finger in the position that they want to really assess their pelvic floor to see how they're responding. And again, it takes a lot of practice because, for example, we go to the bathroom every single day, or most of us do, number 1 and number 2. So it's really easy to sort of connect with our perineum. We do it in a very unconscious way because we do it so often that it becomes like more habitual. But if you lie down on your back and you try and get that same sensation, you're completely thrown off. It feels different, right? Yes. And then I say, like, add an epidural to that, you really don't feel anything. Then you really have to sort of rely on like the muscle memory and the practice that we did before to properly bear down. Yeah. So with that being said, Riley, I really feel that there's going to be a growing interest in this topic of conversation. I feel like today, there's so much more awareness and education compared to when I gave birth 7 years ago, which we didn't really have access to like the same social media and like resources. And obviously even research wasn't as strong as it is today. But what I can say is that a lot more healthcare providers are being more open-minded. I do want to mention one more thing about positions that I do sort of empathize with, like the Western medicine, is that because you are plugged into so many machines and you have these electrodes monitoring on your belly, it really makes it difficult to have someone in like an all-four position, for example, because there's so many things in the way. So I feel like it's hard to have the best of both worlds. You know what I mean? Yeah. I feel like to a certain extent, you're limited in a hospital environment. And then in like a natural birthing house, it's just like a different experience. In either case, I really invite people to embrace the process and learn more about it and be prepared. Like if you don't want the epidural, you have to know what are the things that you're going to tell yourself when things are getting hard, or what kind of support you need from your family or from your partner. Maybe bring music that could allow you to relax, like how are you going to breathe into the pain? What positions do you feel might be beneficial for you? And I think this goes a little bit above and beyond sort of what we do in pelvic floor physiotherapy, to be honest. I particularly am very passionate about this because I went through the process and it really connected with me. But I try and keep it more pelvic floor based. So if they are searching for something above and beyond that, then I will maybe suggest like a doula or someone else who's more knowledgeable regarding this topic of conversation. Do you know what I mean? Okay. I'll just open them up to like the ideas of it, But again, we
Yeah.
are sort of limited with our knowledge and what we're able to sort of do in that
Hmm.
area.
Absolutely. There's this
Yeah.
concept, actually, I was curious to get your thought on it, is that, your uterus does the work and that you don't have to push. I've also had a few women who have delivered in hospitals, and they are like, I had this overwhelming sensation that I needed to push. And the nurse yelled at me, "Don't push, the doctor's not here." And then she actually ended up with like a very severe tailbone injury. Not saying that that's what's going to happen each time, but I was just curious to get your thoughts on, like, because not everyone knows the uterus's role, and exactly what is happening when we're having a contraction. So just kind of trying to get your thoughts on that.
Right. I would say, as far as I know, when you're getting a strong contraction, it's the muscle around the uterus that is contracting with the intention of bringing the baby and lowering it down, massaging and sort of softening the cervix to dilate the cervix. Again, as far as I know, the pelvic floor muscles do not contract, but they do lengthen down and out to move out of the way to allow the baby to pass. So if you're feeling that sort of heaviness and that sensation that you need to like allow the baby to go, but then you're contracting, resisting that movement when the baby's head is so low, I can see how the tailbone would then get in the way of that. And that could maybe
Absolutely.
lead to like an injury because they're trying to hold it in. And the only way to
Okay.
do that is by contracting their pelvic floor. But I
Okay.
do agree with that. You don't, you're not, there's no contraction in the pelvic floor. The pushing comes, well, the contraction comes from the uterus. The pelvic floor's role is to get out of the way. It's to
Makes
lengthen
sense.
down and out and to really allow the baby to pass with less resistance.
That makes
Yeah.
complete sense. Um, so everybody that I treat is scared to tear. Well, every woman that I meet, actually. So I was
Yeah,
wondering if we could break it down. If you know the stats
sure.
on tearing, how common it is, and if there are any risk factors.
Okay, let me try and go back here. So certainly we know that the use of instruments are not favorable, and there is becoming sort of more awareness in the hospitals that, for example, forceps can increase trauma. So we're trying not to use them as much. I mean, I'm going to speak on behalf of St. Mary's because I know that for sure, but I don't know about the other
Yeah.
hospitals.
Hmm.
But, initially it was more like we have to save the baby. And now it's more, okay, well, let's be mindful of like the quality of life of the mother after, you know what I mean?
Yeah.
So they're just taking more factors into consideration. So
Hmm.
with that being said, the use of instruments we know is a cause of like more trauma and weakness in the pelvic floor. We mentioned in our first podcast, part one, how the size of our baby is so over 8 pounds, the circumference of the head being over 35 centimeters.
Hmm.
Uh, I'm missing one. The time that we push, if it's over 2 hours, that could be a risk
Okay.
factor as well.
Okay.
I think when we're looking at positions, there is more evidence that we need to know like for sure. But it appears that the lithotomy position on the back could also increase trauma. I'm going to leave that open ended.
Okay.
Yeah. What else? I'm
I had
thinking.
seen on
So,
social media that there was some sort of stat, the length of the perineum can have an effect too. Is that something that you've heard is a factor also?
that's really interesting because internally, when I do the assessment and I feel that there are more restrictions and more tightness and the outlet isn't able to lengthen and open, I sort of foresee that they might have more difficulty in their delivery. Do you know what I mean?
Absolutely, yeah.
Versus someone who's able to really bear down and lengthen, I know that they're going to most likely have a better experience. I can't say for sure because there's other factors like the umbilical cord and things like that that can affect like their delivery. But I would say yes, that the length of the perineum ultimately and their capacity to lengthen and open can affect it. But I can't say scientifically for sure.
And then the other one that I have had a few patients tell them is that their pelvis was too small to deliver.
Right. I'm going to say the body has a way of really working for you in a really miraculous way. There's a lot of hormones that are secreted, and I can't say for sure whether that's true or if that's a myth, that their pelvis is too small. I know that if they do like an echo at 32 weeks or that like later on and they suspect like a really high percentile, that they'll do a test to see the width of their pelvis to make sure that the baby could pass.
Okay.
But I want to say that it's thrown out there maybe more than it should be. Do you know what I mean? Because I feel like a lot of it isn't about the width as much, but about the tension and how the pelvic floor muscles can be clenched, which could really narrow their pelvic outlet and make it difficult for the baby to pass through the birth canal.
Okay.
Yeah.
That makes sense.
Yeah.
Yeah. You had brought out your pelvis to explain something and then I cut you off.
Oh, because we were looking at perineal tears. I think that's like a frequent question that we see. So for those who are watching, they'll see it on my pelvis, and I'll try and describe it for those who are not watching. So a grade 1 typically goes into like just the tissues and the skin at the vaginal entrance. It's very minimal and very rare. Typically what we'll notice is a grade 2 tear, meaning it's starting to enter the pelvic floor like muscle. I'm pointing at the bottom because, and I think this is a really good view of the perineum. The center of the outlet between the pubic bone, the tailbone, and the sit bones is going to be right here that we call the central tendon or the perineum. So when the baby descends the pelvic outlet, it comes down the center, but it exits the vagina. So there's not much room for stretch in the anterior, in the front part, because we have the bones that were, the pubohamia, the bones here. So the stretch is going to happen more in this area, which is why we always, suggest or we teach our patients to relax not just from the front, but from the back as well, sort of releasing the anal sphincter and all those muscles back here, because we need these muscles to lengthen down and out to allow the outlet to open fully. Does that make sense?
Yeah, it makes sense.
So with that being said, the tearing happens mostly at the bottom and less frequently at the top, although some women have what we call a periurethral tear, which is like a little tear towards the urethra, or sometimes it could be on the labia as well. But most of the time it happens down in the pelvic floor muscles. Now, if the tear starts to enter, I'll come closer. If it starts to enter the external anal sphincter or like these muscles back here, that's what we call a grade 3. But it hasn't come down all the way into the rectum. If it does, that is a grade 4 tear. So grade 4s, I believe, they're like under 5%. They're really not prevalent. Off the top of my head, the grade 3 is something like 25%, give or take. And like majority is a grade 2 tear, which is a couple of stitches like at the, surface level of the perineum. Not affecting so much of this area back here. Make sense?
Absolutely. Yeah. What are some things women can do to help prevent tearing?
To prevent tearing, we know for sure now, which is really exciting to say on this podcast, as of 2020, we got this incredible meta-analysis showing that women who did the perineal massage 34, 35 weeks of pregnancy had less risks of grade 3, grade 4 tearing, less risks of an episiotomy, and reduced second stage of labor, which is pushing. So we know that it's not just about the stretching that increases sort of flexibility in the tissues, but it's also about learning how to relax into the very intense sensations that you're feeling, that you'll want to contract. So like voluntarily putting your finger there and learning not to resist it, but how to allow the muscles to like even melt beneath your finger and lengthening down and out as you pull, and having that, like your brain sort of understand how to relax and not grip in anticipation of what they're feeling. It's a combination of both.
Makes so much sense.
Totally. And I will also add that the pelvic floor muscle training program that we do, so just to be more clear, it's a group of exercises that we give, and they're truly individualized according to what your needs are. So someone might present with, very tight muscles and like a very narrow sort of vaginal entrance. And for them, I certainly work more on the relaxation, flexibility, gaining full range of motion, bearing down, versus someone might present with a lot of weakness and a lot of lengthening. They could be like CrossFitters, going back to that from the bird episode, where they're known to have like really weak pelvic floors, or it could be that they have other symptoms of weakness. I'm going to maybe favor a strengthening exercise program for them. And so depending on the assessment, we try and see what your individual needs are and what your goals are as well. Because I have some women who wish to continue CrossFitting when they're pregnant, and that really means a lot to their sanity, and others who just have no desire to do any physical activity whatsoever. And so I have to go back to the question.
Well, just you take all of that into consideration with what you suggest for prevention of tearing.
Yes. Right. So then exactly having that control in the pelvic floor muscle. So when you're doing those exercises, you're really optimizing that control of the muscle. And so when it comes time, for example, to push, you know how to do it because you've practiced it. You know what it means to lengthen the muscle. So having that like newfound awareness and connection definitely helps reduce like the pushing time. And I will add that like on a personal like note, and I feel like we totally need more studies to validate this, but I've had so many mothers come back afterwards and say like, the fact that I knew what I was doing and I was in control, I felt like I was pushing properly, and I felt like I was able to have not only a better delivery, but a much quicker recovery. And I was able to integrate my exercises after to restore my muscles. And I knew what that felt like. And they're like, this was so valuable to my experience. Like, thank you. I don't see how I could have done it without this like information. You know what I mean? And I felt going through that with my kids as well, that there was such a lack of knowledge, even for me having some sort of foundation in this field, but not as much clinical experience at the time. I felt like this was really missing, you know, and it's unfortunate that we don't know more about this, truthfully, because I would have totally liked to know more about that. Yeah.
Well, when you think about it and you just think about it in like a bigger general sense, any physical endeavor that we do, like I would say that there is no harder physical endeavor than childbirth. Like there is so much at work, and yet it's like we don't talk about it. We aren't told we should prepare for it. It's just like, just show up. If you're going to run a marathon, you're going to do months and months and months and months of training, and that's for 4 hours. Like I have very few women who are in labor for only 4 hours on average. Or when you're studying, like when you have a test, the reason that you study is because it's a stressful environment and you want to be able to perform under stress. And the only way that you can do that is through practice, whether that's physical or mental. So I just think it makes so much sense to be prepared before, because it is a time in your life where I've never given birth, but this is what I've come to understand, is that you feel like you're losing control of what's happening on your body. So for me anyways, I would want to feel like I can control as many factors as possible. So if that's my ability to tap into the breathing exercises that I've practiced over and over so that I'm not clenching my pelvic floor or whatever that may be, it just sounds such like a common sense, useful tool to have on the day.
No, I couldn't agree more. I feel like a lot of women don't even know where they pee from, that they have a hole for their urethra, or they don't fully understand that there's all these muscles at the base of their pelvis, and that there's like literally no bones down here so your organs can, you know, come down, or they don't fully, or they don't.
It's so true.
Right. Or like they'll be really adamant about, you know, doing certain exercises while they're pregnant, but they're not loading properly, or they're like pushing too much into their core when you're growing a fetus and your muscles are already subjected to so much loading and they're already being stressed and elongated to their full capacity. And so adding that additional stretch, it's like really not the time to do so unless it's been done impeccably. And this is a little bit of a pet peeve, because sometimes on social media, we'll see these like really fit girls doing these pretty incredible things, but truthfully, that's like 3% of the population. The other 97% are maybe not loading properly, or don't have like the best alignment, or they're just bulging way too much. Do you know what I mean? I think that bringing these changes and awareness, and this is what we do a lot of education in that first session, to allow them to connect with their bodies and like understand what is happening.
Yeah.
And they so appreciate it, you know? Yeah.
I think
it needs to be done more. Yeah.
Absolutely. And I think that stems from this like hardcore society where it's like, you know, you need to be productive constantly. And I find it such a shame that that has entered in the pregnancy realm. And I don't think by any means that pregnancy needs to be treated as like an isolated pathology where you just stay home and rest constantly. But I also like just think like, why is there that pressure where women feel like they need to prove something physically? Like you are freaking growing a human being inside of you and everything in your body is changing, like hormones, where your organs are, how your alignment is, like your flow back is being, it's just your center of gravity drastically changes. And it's just your, you know, all of the running technique you have previously learned, all of the other technique you've previously learned has changed. So it's not even really that possible to apply those learnings to this changing body, if that makes sense.
Absolutely. And I have some really good news to share, actually. We
Okay,
got
great.
some really good news last week because I think the point of our podcast and bringing two like-minded people together today is that we're so passionate on how this should be offered and like really taken sort of more seriously in terms of prevention. And we're so confident in like what this could bring to our audience. So on that note, I'm going to go on my phone because I want to say it properly. But last
Yeah.
week, we got some really, 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 really good news in Quebec. In 2019, le ministère de la Santé et des Services sociaux, they gave a mandate to the INESSS, which is Institut National d'Excellence en Santé et Services sociaux, to
Okay.
evaluate the pertinence of integrating public pelvic floor services in Quebec for the
Wow.
prevention and treatment of dysfunctions in the female pelvic floor. And so we had Chantal Dumoulin, Claudia Brown, Mélanie Morin, a lot of head researchers that were very strong in Montreal. So they all came together. I hope I didn't leave anyone important out because there's so many people who worked really, really hard on providing like a really strong sort of thesis
Mm-hmm.
or recommendation. But they published their premier volet like last week. So they're making a big demand or in demand, I hope that's the English word,
Same
to the
word.
government. Yeah. So we just got news last week that there has been like a big demand for the government to provide a budget for these services. And so
Wow.
everyone cross here, this is like really big, really big.
This is
Yeah,
huge.
it's huge. It's very exciting. And we're hoping that this would be more accessible like in the future because, you know, I think it's important to mention that if women who are pregnant and postpartum limit their trauma or have a better
Mm-hmm.
experience and have a better recovery and they restore their core and their pelvic floor postpartum. This
Mm-hmm.
will absolutely, and we know this for a fact, actually I have the stats, it reduces leaking in pregnancy by over 50%. It reduces
Wow.
leaking in the first 3 months postpartum by 50% and also reduces leaking beyond the 3 months postpartum as well as organ prolapse. So
Wow.
we are hoping that by addressing this in terms of prevention early on, this will lead to like less dysfunction over time.
Makes
Yay,
so much
right?
sense.
I know.
Absolutely. I did not
I
hear
know.
about this. This is great news.
It's big. It's like really
Yeah.
big and it needs to be shared. It needs to be talked about and we need to keep
Yeah.
pushing for that because it's great news. So let's
Good.
see.
I'm really
Yeah,
happy to hear that.
me too. Me
um,
too.
yeah. So
Yeah,
speaking about postpartum rehab,
sure.
how, so actually is that there, I know a lot of women have felt this as of late, is that the postpartum checkup for a lot of women that I treat, it's being canceled, it's being postponed. There's a
Yeah,
massive
the
drain
checkup.
on the healthcare system. Yeah, massive drain on the
Yes.
healthcare system. So I always refer as a gold standard, even before this, but how soon can women see a pelvic floor physiotherapist after birth, or what is the recommended time frame?
Sure. So typically to allow the incisions to heal, whether it's a C-section or like a vaginal tear, it's going to be at least 6 weeks postpartum. So for that reason, we
Okay.
don't do any internal assessment and we don't mobilize the scar before that to allow it to heal and
Okay.
minimize infection. With that being
Okay.
said, if someone is in pain or the pelvic outlet remained open and they want to consult for something else, they totally can. They can come
Okay.
before. We just can't do an internal assessment.
Okay.
What else? They can start exercises before. This is like primarily without a C-section. They can definitely start integrating like some core breath exercise and very gentle pelvic floor exercises in the early
Okay.
weeks postpartum, but then we'll kind of check what's the status, when they come to see us. And going
Right.
back to what you initially said about their appointments being canceled, I think because of COVID, they tried to limit the contact with their patients, and they were doing things more like over the phone, which is pretty crazy because that means that no one's really assessing their perineum postpartum, and they're asking questions about like bleeding and symptoms and so on. But one of the questions that you had asked me, and I'm going to answer it now because it was something we spoke about maybe before, was like the difference between the OBGYN and a physical therapist. It's totally different, guys. We're physical therapists. Our expertise lies in musculoskeletal dysfunction. So we don't look at anything medical, whereas their assessment is like pretty much all medical. You know what I mean? They're not experts in muscles, and they leave it to us.
Yeah.
And they'll openly, by the way, I do have to mention that we have stats on this. I don't want to say it properly because this is also like pretty amazing. So we have recommendation grade A evidence, which is the highest in research, that pregnant women having their first baby should be offered a supervised and intensive pelvic floor muscle training program to prevent postpartum urinary incontinence. This was a Cochrane systematic review.
Yeah.
A newer one also suggested training in prevention and treatment of urinary and fecal incontinence in postnatal women. This is another Cochrane review as of 2017, which is like a pretty good database, as we know.
Yeah.
And I also want to say, because, some patients will say like, oh, like my doctor didn't tell me, or like they don't know. And I get the impression often that doctors feel like it's a burden because it is private and it's very expensive. And that they're like almost, holding back. Some of them do mention like, hey, by the way, this could be really beneficial. I always try and tell them when I see them to be like, just leave it up to them to decide if that's something that they want to do for themselves or not. You know what I mean? But I do want to say that the National Institute of Clinical Excellence, which is the NICE in the UK, and the Société des Gynécologues de Canada, the SOGC, recommends pelvic floor training to all women in their first pregnancy for a prevention of stress urinary incontinence. So I just want to put it out there for anyone who's not sure that we have these really, really strong guidelines in place, and that we really know for a fact that this is truly beneficial and that it's very preventative.
Right.
So I was excited to share that with you.
I'm very excited that you shared that with me. I mean, the evidence is there. And I mean, as an osteo, I know that everything government related can be very, very slow. We've been trying to get an order for like 30 years, so everything takes time. But the more research there is, I have no doubts that we will get there, It's so important.
So important.
Yeah.
I also want to go back to what we were talking about postpartum, and not just assessing the pelvic floor, but assessing the core as well. We often forget about that. Even if you had a C-section, your abdominal muscles definitely had some sort of impact, and you can have like what we call a diastasis or abdominal separation.
Yes.
And aside from that, there's been a scar. And, if we look at any other protocols, like an ACL repair, a fracture in like the tibia, or like even a shoulder injury, the first thing that we want to work on after a surgery is the scar mobilization. Because if the scars remain like rigid, it could affect the range of motion and the progression of that athlete or that patient. And so like, why is it any different with a C-section? How are we not mobilizing these scars after? And, women are like afraid to almost touch it. Oh, by the way, I saw this incredible post that you put on your story about massaging. I actually saved it because I was like, this is great to show the patients. But,
Awesome.
and about like moving it. And I'm like, man, why are we not talking more about this? Because it just makes so much sense that we do this literally for every other injury in the body. And we learn about like deep tendon frictions and having these fibers, heal in a more organized fashion, that there's like less adhesions, less tethering, again, like it could tether into different structures. And it's like, we need to absolutely talk more about this.
Yeah.
And it's sad
I could not
because
agree
the
more.
women will come and they're like, I still have sensitivity or pain with intercourse. And it's like, well, have you tried desensitization strategies or like just gently working the scar? And they're like, oh, no, I don't want to go there. It's like, but we have to start slowly communicating with the nervous system. And there's like ways to desensitize and to like ease into it. It doesn't have to be don't touch it to having full blown intercourse. There's a
Absolutely.
way to sort of ease into that and to
But
do it
sometimes
properly.
if when you're not in the field, you can't even think about those options, you know? It doesn't come to mind. If you're not in the field, you might see it very much as that, like option one or option two, and that's what's so great.
So,
But I can't wait for this to improve more so that it's more common knowledge that, there is such a greater spectrum of healing. And like you said, in other domains, like my partner, he's an orthopedic surgeon at St. Mary's actually also. It's like
okay.
for every surgery that he does, it's like there is protocol week one, like even like within the day, like it's so straightforward. Meanwhile, this may, and that's arthroscopy, and then meanwhile for C-section, we're cutting through, I think it's 7, 8 layers and
Right.
nothing. Even so far as I've had some patients who said their doctor said, mobilizing your scar does nothing. And it's like, no, like I have the receipts on that. I did my project on scar therapy, my thesis for osteo school. And like, it is
Said that.
thoroughly backed up now.
Oh, for sure.
Yeah.
Yeah.
It's frustrating.
Yeah. No, definitely. That made me think of something because you were mentioning protocols in place. And I find, so for example, if someone has, so no two birthing experiences are alike. Correct? Some may push longer, some don't, some end up pushing and end up in a C-section. So it's important to highlight that there can be it's not a protocol like a knee where it's like the same sort of tendon and like there's a protocol for that person. What's really interesting about consulting, and I'm sure it's the same with you, is that, for example, if I have a diastasis recti, which is an abdominal separation, I will look at the depth of that diastasis. I will look at the severity of it, and I will challenge that person to do an exercise that is valid for their situation. So I'm going to see how they're accepting the load and how they're really engaging their core. And I will find the right exercises that are suitable for them at that particular time that will allow them to heal. And that could look really different for two people at week 6. You know what I mean?
Makes sense.
So I find that these exercise on YouTube or like what they're hearing or what their trainer's telling them, unfortunately, isn't a one size fits all. And it's very much the same for the pelvic floor. Like if you had a 9-pound baby and pushed for 2.5 hours versus a 7-pound baby you pushed for 30 minutes, your recovery will be extremely different. And you can expect that person who maybe had more trauma to want to be sitting more and feeling heaviness, have more just difficulty, like going to the bathroom and connecting with their pelvic floor. That could look really different for two people. So I do want our listeners to recognize that and to know that it's not a one size fits all, and that we're able to see more specifically like what your needs are, but also what your goals are. And again, the goals can look so different. Like some people just are wanting to go back to high intensity so quickly, whereas other people don't care for it. So if you want to go back to like mountain climbing or rock climbing, I got to get you, your pelvic floor needs to be ready to handle that load. Whereas if you want to go back to just being a mom and walking around the block, then you have to be ready to accept that load.
Yeah, absolutely.
Yeah.
There's definitely a lot of like one size fits all stuff there. And when you were talking about the trainer, it just made me think of our previous episode, like, if the personal trainer, there are only 3 professionals who are allowed to do internal exams, nurses and gynecologists, right? So if the trainer is giving core exercises, but never has a chance to evaluate the pelvic floor, then how can that be really taking the entire abdominal volume into account to ensure prevention and proper rehabilitation? So I just to double down on what you said. Yeah.
There's no way. If they're going back to physical activity after, you don't know until you're in there. There's no way to see. There's no way to know. It might look like blocking your breath or sort of bulging down. It might feel like some sort of heaviness that's there. But unless you're like in the pelvic floor, there's no way to know. Aside from gynecologists, though, there's also family doctors who can do an internal exam.
Okay. Oh, that's true. And I should know that. My best friend does that. So she's a family doctor who did her fellowship.
Yeah. I think that's it, though. I think those are the 3. Yeah.
Yeah, makes sense. What else did I want to ask you? I just had a thought Um, oh yeah, so I do have some people that reach out to me occasionally where there are no pelvic floor physiotherapists around them, and they still don't they explain to me that their gynaes didn't even do an internal exam for their postpartum checkup. So I was wondering if you could just touch on some signs postpartum where it's like, okay, we really need to start, like, these are the things, like, basically don't get involved in any physical activities until XYZ resolves. Like, someone was like, I don't know if I can start walking again. Like, what should I be looking out for? I have no professionals
Right.
around me. Yeah.
I mean, you should never have any symptoms of like pressure or heaviness or leaking. I mean, I feel like that's maybe obvious, but maybe not to others. You shouldn't really have any symptoms, even like in your lower back or anything like that. It should feel similar to what it did before, essentially. About not being able to find a healthcare provider like or a physiotherapist working in pelvic health, what they could do is also go on the order website, the OPPQ. They can type in their postal code, and it will show that if they click on like an option, rééducation périnéale, it will show everyone who's practicing in their area.
That makes sense.
The thing about rééducation périnéale, and we talked about this a little bit in the first episode, is that even in that, there's different areas of expertise. You know what I mean? There's different levels of, or different courses that are offered that could be more geared towards like pediatric, geriatric, oncology, peri-postnatal. And so with that being said, if they're not sure, they can always maybe even ask the clinic and be like, hey, I would really love to come for prevention. Is that something that you offer at your clinic? And just try the clinics like in your area, because they are becoming a lot more in demand. And there's a lot more physiotherapists that are becoming trained for that, which is really exciting.
Good.
And so I feel like it's becoming more accessible, you know? But yeah, if you're having any leaking or heaviness, I'm trying to think of anything else that'd be really obvious and like,
bleeding.
there's really a problem here. Oh yeah, well for sure. I would hope that they see their gyno before and not wait to see a pelvic floor physio for bleeding. I think bleeding is more of a medical condition, truthfully. I don't think that they should go consult with their doctor if they're bleeding, for sure. I mean, it's normal to bleed up to a certain like time.
Yeah.
I feel like if it persists beyond a couple of weeks, then it's something that you want to address with your doctor.
Okay. And then I'm guessing all the things that you just said, would it be the same thing before intercourse? That's a question that I get.
Oh, yes. Pain with intercourse. Yes. If you're having pain, then definitely it's seriously just a miracle worker. I feel like women have to deal with pain for so long, and we do like a little bit of manual therapy, some releasing, and they feel so good after. It's really gratifying treatments for us as well. It's like so fun to do because you sort of feel where the tethering, where the trigger points, where like the tightness is. And within a couple of minutes, you definitely feel the muscles. It's like a massage anywhere else in the body. And it makes so much sense, right? If we have like our tightness in our shoulders, or we have some knots and you work through them, you're like, oh my God, I feel so good. I have more movement and range. It's literally not like no different. I really compare that to it's muscles at the end of the day. So if we feel some like tightness and restriction through manual therapy, we can do so much fantastic work. And this is a large part that I love so much what I do, and I'm so passionate, is because it's such a gratifying job. Like it just works so well, so well. And if we foresee that there's other issues to take into consideration, like if there's a vestibulodynia, more sensitivity, or that we have to work with like instruments like a vaginal dilator, then that's something that we'll of course recommend. It's not just manual. There could be other considerations like vaginal hygiene, and oh my God, I could go on and on and on. Another topic could be like vaginal like estrogen cream if there's like a lot of dryness from vaginal atrophy from breastfeeding, mainly women who are pumping or breastfeeding, they are getting a taste of being a little bit in menopause, actually. They're getting those heat flashes, that vaginal dryness, right? So there's definitely more sensitivity for them. So with that being said, we make some recommendations like lubricants and just sort of splaying the vaginal labia, but also they could get prescribed from their doctor like a vaginal-based cream, estrogen cream as well to help with those symptoms.
What does splaying mean?
Oh, so splaying the labia would mean I'm going to show you on the video, but for those who are tuning in, you would essentially open the labia minora out of the way so that when the penis is coming in contact with the vaginal entrance, like not rubbing everywhere.
And where there's dryness, essentially. Yeah.
or discomfort or like, or any sensitivity at the vestibule, which is the area between like the small lips and the vaginal entrance. So if we just gently splay the lips right before and add some lubricant, this can really make the insertion a lot more pleasurable, less painful, like less contact, less friction. Because the more friction there is, the more burning, the more anticipation you're going to feel. So it's a little trick that we like to give.
Yeah, that's great. Perfect.
For sure. I think pain can be really simple, but it could be really complex as well, as you could see. Because you've mentioned so many different ways of treating. I think oftentimes it is quite simple, but it can be deeper than that. And there could be more like psychosocial issues as well in that. So I just want to be mindful for those who it's not so straightforward and they kind of deal with a little bit more than the surface level, you know?
Yes, absolutely. Okay, well, that's all that I had for questions. Is there anything else that I missed or that you'd like to talk about?
I think we spoke about everything. That was great. Let me just check real quick. No, I think we covered everything.
Perfect.
Great. Amazing.
Okay, well, part 2 is wrapped up. Thank you so much for your time again.
That was great. That was so fun. This was really nice. Thank you for having me. And
I think it's going to be super helpful.
I think so.
Oh,
too.
how can people reach you, or are you still taking new clients? And how can somebody go about making an appointment?
I work in the private sector and I'm at part-time right now. I work out of 2 clinics at the Kinetics Rockland and TMR and a clinic in Laval, Chamonix called Santé Laval, Osteopathie et Physiotherapy. So definitely they can call the clinic and speak with the receptionist to find a time or like an appointment. But I will say that there is currently a bit of a waiting time, so they might want to call in advance. Otherwise, I do have social media that I'm not as active as you, but it's MTL Pelvic Physio.
She's great on social
always
media.
Contact me. I try to when I have time. But I think you're my inspiration. I don't know how, it's so time consuming. You're so good at it too. You got to teach me a couple of things. I don't know how you do some of those videos.
I'd be happy to.
Like the reels and stuff. I can't do any of those reels, or like, I don't know how to put background audio.
It took me a while to figure it out. Well, those ones are, we need more of those, just the concrete, good info.
For sure. So with that, I'm on MTL Pelvic Physio. You can come message me there if you have any questions. And if there's anything that we didn't speak about that they want to know, be sure to let me know so that I talk about it maybe in our 3rd podcast.
Yeah, we'll definitely have to do that again. All right, well, have a great rest of your day.
Thanks so much.
I'll talk to you soon. Bye.
Okay, bye.